Good afternoon, everyone. Welcome to our November 10th meeting of the Arlington County Board. I'm without a gavel, so I'll just clap us into session. Just for context for folks, we are going to have a conversation with our manager this afternoon in open session regarding a COVID-19 update. I do think two quick intros are in order. First, just congratulations to our chair, Libby Garvey, who has won re-election. And then also, and we'll have additional comments, I'm sure, at our regular board meeting. And then just an acknowledgement that we've had a major election in our country, and a thankful note for all of the poll workers and people who have helped make sure all votes are counted. We are reaching a conclusion, and it's fairly clear to most of us, and it's been a big moment in our country's history. So we will proceed with our county managers' issues and updates with respect to COVID. And I think epidemiological, we may head towards Mr. Varghese, but I'll send it over to the manager.
Thank you, Matt, and thank you, members of the board. So this afternoon, it's been a while since we've been able to have Dr. Varghese present with all the board members, and I'd like him to walk through a summary of where we stand on outbreaks in the county, trends of what we're seeing. You know, the national narrative has been that there's been a spike in cases, and wanted to inform people how Arlington is doing in that situation. Also, there have been some specific cases at Marymount, Bishop O'Connell. Then also walk into a little bit about our testing strategy. And I think it's appropriate. We've waited a while because the plans have been a little bit squishy to talk about the vaccine and the potential for a vaccine and what would happen when a vaccine becomes available, how we would go about handling that. And then I also think a thing that's top of mind for many Arlington residents, which is what's going on with schools, and to clarify, and I think in some ways, the relationship between the county and schools about making decisions on various items. So I will turn it over to not only the greatest public health official in America, but the greatest one who wears a bow tie, Dr. Ruben Varghese.
Okay, not sure how I'm going to top that. I'm hoping someone has the slide presentation already, or am I sharing my screen? Because that would be an interesting phenomenon. Am I sharing my screen? No. Okay.
Ms. Jacobs, I think, is going to pull up the presentation, or someone is going to magically help it appear. Is that right?
I'd be happy to help you out if someone could send me the presentation.
Okay. Maybe you can send it over, Mr. Varghese, and Ms. Jacobs can help us.
I will do that, right?
And Mr. DeFranti, maybe while we're doing this, I'll take this opportunity while we're waiting just to thank you for chairing the meeting for me and explain to people I am in Maine and the connectivity is a little iffy here, and I've got a house that may soon be invaded by 6 small children. So I'll kind of be going in and out, and I appreciate you running the meeting for me. Thank you.
Thank you, Madam Chair, and thanks for giving us that context. It has been a busy couple of weeks for a lot of us.
Yes, I just sent it to you.
It's interesting how it gets darker earlier here. You'll see, I'm going to need to turn on lights here. We're a lot farther north, so.
Well, while Kendra's pulling up, I do want to just allow you to realize that what's happening nationally and regionally is also happening in Arlington, and especially with the delay in testing results coming in, even you will be surprised when you see how much we've increased just in the last several weeks, because the testing delays sometimes come in, and so we have reached the second highest level of cases by week in the entire pandemic this past week. And so that will maybe come as a surprise to some, but it doesn't come as a surprise to us in the region, because we've been seeing that everywhere cases have been rising. And while there are many explanations, including there is more testing available, the fact that this number of people are positive is the real issue. And so and there are reasons probably for it, but I just want to be able to provide that context. And the biggest pitch is that we need the community to still not get COVID fatigued and take care of themselves and others by doing the right things, which most people are. And let's be gentle with ourselves. If you forget, do better the next time. So,
So we're seeing there we go.
okay. And Kendra, if you could start with the second slide, which you have right now, would be perfect. So this is a little different from the slides that sometimes have been shown at the town halls. And I just wanted to show the complete aggregate experience. This is the entire pandemic cases for since March through week 45, which ended last week. So this is the pandemic curve, and people are familiar with it, but I'm going to go through it very slowly again. So you'll see the weeks listed along based on CDC weeks for one of their reports, and the months underneath them. And then on the vertical or y-axis, the cases. And I'm hoping we don't have to have a adjustment beyond 350. So you'll see that we peaked at 306 at week 18, which was somewhere in May. And that was between phase 0, which is when the governor had his executive orders ordering everyone to stay home. And then as that started to take effect, you saw a decline in cases, and that decline continued even when we went into phase 1, which was allowing 10 people to gather. Phase 2 at week 24, where 50 people were allowed to gather, and it was only at phase 3, which was July 1, where 250 people or less were allowed to gather, that we saw a gradual rise back in cases. But it was going up and down, but you'll see that in October, we've seen a steady increase, and it's continued. And so there's a delay, obviously, in the lab reporting. That's where illnesses or labs may not have been received by us, because there is a delay in lab reporting. And so we've just seen a steady increase. So it shouldn't come as a surprise. And I'm going to summarize and say that by age, every single age group that we've talked about before, including those under 18, have seen a rise. In the last week, we saw 24 people under the age of 18 who were positive cases. So there isn't a single age group that hasn't actually seen a rise at this point. Same thing for race and ethnicity. Every single race ethnicity group has seen a rise. The disproportionality still continues, but every single race ethnic group has seen a rise. Every zip code has seen a rise. This is not a localized phenomenon. And as I've said, it's not just in Arlington, but for those who want Arlington-specific data, this is an important thing to see. Kendra, if you could go to the next slide.
Dr. Varghese, I think our chair, Libby, has a question, maybe on the last slide.
Yeah, thank you. A real quick question, Ruben, on the last slide. It's just a statement or an observation that some people might not pick up, because you've always shown us these slides, and usually in that grayed out area, the line is down, and you always warn us that it's going to be higher when more cases come in. I've never seen it recently where the lines have been going up like this, and if they're in the shaded area, they're likely to go up even more. Am I remembering correctly, or has the counting changed? Are we getting better with the number of cases reported on time?
No, you are absolutely correct, Madam Chair. That is absolutely, unless there's some errors in the data, we're going to be expecting those numbers to rise. How much, I can't tell you. Obviously, it depends on what's out there, which we don't know. But yes, I expect those weeks to continue to rise. And then as the next weeks come along, that's what we're looking to see, what the new data will show.
Thank you.
Great, thanks. There we go.
So I just wanted to show you some of the information of the pandemic metrics that the Virginia Department of Health looks at by region. And so I've cut and pasted these things together from that slide. So this is, of course, the picture of the Commonwealth. And the first graphic at the top, paying attention to the key that goes minimal, that's in a gold, all the way up to high in a dark deep blue, you'll see that the entire Commonwealth is either at the moderate gray level, mid-gray, or to the dark blue, blue-gray level. There is not a single place in the Commonwealth at the moment that's at low or minimal. And then if you look at the Northern Virginia transmission extent, it essentially is showing the pandemic curve, in a sense, the experience of Northern Virginia, that, you know, back in February, we were at low. In May and June, we were at a substantial level of transmission. Then it went down, and for a long time, we were at minimal, then had a spike approaching substantial, went back down, and once again, we seem to be approaching substantial. So this will be the the ways that can go. I'm hoping that we're going to go back down rather than getting too substantial, but we're getting closer. Next slide. And so these are some of the metrics that I've talked about before. Sorry for the shorthand, and I'll try to address all of the things. These are the metrics that BDH and the Northern Virginia health directors have looked at from the very beginning. So, for example, the daily case incidence rate, that's the number of cases per 100,000. We're currently at 14.5. The materials in the parentheses are the lower and upper bounds if they happen to have it. Something below 5 would be ideal. Being above 10, which is what 14.5 is not where we'd like to be. And then we look at how many days has that trend been, and it was increasing for 21 days. And the threshold to say it's either going up or down is if it does that for 14 days. So our analysis is that this trend has been increasing. The daily PCR percent positivity rate is what the rate is for Northern Virginia. So, and I'll show you where we are later, but for Northern Virginia, we are at 6.1%. The upper threshold is 10. Obviously, the lower one we'd like is 0. This has been increasing for 25 days. It goes beyond the 14-day threshold, so that's considered a trend that's increasing. The rate of outbreaks per 100,000, and what you have to realize is the definition of an outbreak is 2 or more cases of spread within the same person, place, and time. You have to have all 3 conditions. We don't usually say 2 cases in Arlington because that's usually not the case, but we want it to be the same geography, like the same location, and in the same place and time. And so that has been decreasing for 9 days. We haven't had reports of that, but the threshold is 14 days. You'd have to have 14 days of decreasing for it to be called decreasing. So this is considered fluctuating. The case percent among healthcare workers, this is an important value to see how well our infrastructure is able to respond to things, and they're doing infection control as well. Because if you saw a high case percentage among healthcare workers, you'd be worried about the healthcare system, especially the hospitals, about what sort of protections are in place and how many cases are there. So the burden is at 2.8%. Being above 5 would be considered to be poor in this circumstance. So fortunately, this has been decreasing for 18 days. It exceeds the 7-day threshold. It's considered to be a trend that's decreasing. Visits to emergency departments per 100,000. This is 4.1 rate, and it's been increasing for 20 days, which is higher than the 14-day threshold. So that is considered to be an increasing trend. The rate of COVID ICU hospitalizations per 100,000. We're at 1.4. Having a number below 3.5 is where we want to be. That's been decreasing for 6 days, but it's not been 14, so it's fluctuating. The percent hospital beds occupied, that's all hospital beds, not just COVID. We're at 77.3%. If you cross 90%, that's considered to be more concerning. This has been increasing for 16 days, but has not crossed that 90% threshold. And then hospitals with difficulty getting PPE over the last 7 days, we're currently at a value of 0. One hospital 7-day period having difficulty would be 1, and we would consider that a problem. We have had that happen once. We've been fortunate more as a region but there are reports other parts of the country have had more difficulty getting PPE because this has not been dealt with in a uniform manner, in my opinion. Next slide.
Dr. Varghese, I think Mr. Karantonis had one question on the last slide, I believe.
Mr. Karantonis, what is?
This is just for me to understand the numbers and the metrics properly. Just clarification. So percent of hospital beds occupied, you said that 77.3% is the general occupation percentage of, and that doesn't only reflect ICU hospitalizations, right? Sorry, COVID-19 hospitalization. Do we have a metric about how many or what part of this is due to COVID, or even more specifically, how many ICU? What is the ICU bed availability for the increased COVID patients that are coming through now the higher incidence?
Sure. We do actually have some of that information. I did not put it in this because it hasn't exceeded those thresholds. And so the ICU capacity has been decreasing, as in the number of cases. So therefore, it has not been actually crossed. Some of the developments in treatment have led to improvements that ICU beds aren't necessarily as needed as before. The other thing that you'll learn with the hospitalizations in general is right now, we still have the governor's permitted elective surgeries and admissions for different conditions. So there's a lot of leeway there for the state to potentially take on cases if, unfortunately, the cases were to get overwhelming. Then hospitals either voluntarily or would be required by the governor to stop elective surgeries. So they would then turn the surgery beds into COVID-19 beds and the like. So, and this is the regular bed capacity. Each of the hospitals has a 20% capacity above that they haven't even exceeded yet either. So there's more play in the system. So that's why I just wanted to present all of that, and thank you for this opportunity to provide that information.
Okay, thank you.
So these are some general points that I wanted to get to, which Mr. Karantonis anticipated. We have not exceeded the hospital capacity, which I want to remind people was the original purpose of flattening the curve, okay? But one of the things that is different, going back to that picture of the whole Commonwealth, when we had that rise in April through June, we were the region with the pandemic. The rest of the Commonwealth really didn't have it at that point. That's different now. You saw that the rest of the state is actually in a worse position. That doesn't mean their hospital bed capacity has been exceeded. But remember, that's part of the state surge plan, is that if we were to ever exceed it, if we needed to, we would be shifting patients to other parts of the state or the region for care. So good part is we have not exceeded it. However, just wanted to remind people the context is a little bit different now than it was back in April or May. So people are going to ask me, what's the most likely reason for the increase? I don't think this is a difficult stretch of the imagination for me to say we are interacting with people outside of our home bubbles, okay? We're socializing. So we're still at the 250 person or less gatherings under the current executive order. More places and organizations are open with in-person work. None of these are bad things, but when we get together, we socialize. The weather can contribute. The fact that we have more cases identified, it is also related to increased testing. There are people testing for a number of reasons, including if they want to travel to other states, they've got restrictions. I had to take a test to go to Rhode Island and be able to prove I was negative, or then to quarantine for 14 days when I visited Rhode Island. So those could be some of the other reasons. But we also have special events. And when we talk about what happened proactively at Bishop O'Connell, as they put it out, there was a Halloween event that they knew students were at. They knew that there were a couple people who were positive, and they didn't want this to become a disciplinary situation as much as a safety situation, trying to get people, as they said in the letter, to tell what was going on and identify. And they took the out of abundance of precaution stance and saying, even though there was no outbreak associated with the school or in the classroom, the potential for exposures could be there if they couldn't identify the students who may have participated. And so they went to, as I understand it, to a virtual posture. So jumping to outbreaks in general, right now we're following 9 places with outbreaks by that definition of having at least 2 or more cases. And they remain on the list for 2 incubation periods because we want to make sure that there isn't surreptitious transmission that we've missed. So 2 incubation periods for COVID is 14 times 2 or 28 days. We have 4 in long-term care facilities and 5 in non-long-term care facilities. And we also have some special situations like the one that you saw with Bishop O'Connell, where there's no outbreak, but we're following it as well, and because we work with the community. And this is what I want to point out is it's really spread within their communities. For those interested in school dynamics, we haven't had significant evidence of any of the schools that are open that there's been transmission in classrooms. So something good. And other situations we monitor are going to be things like, people report to us circumstances if we're wondering if it could develop into that, staff have that spidey sense to check in with them and see what's happening. So that's where we're at roughly with the outbreaks. It's not surprising in a community with a moderate level of community transmission that as people gather, this is going to happen. You mentioned Marymount. It wasn't a classroom activity. It was more, we've seen athletic people on the athletic level interacting, but not on the field. So I would consider that more social gatherings once again. So the places where the protections have been in place, we've seen actually lack of transmission, which is good. If there are no questions on this, I will move on to the next slide. Mm-hmm. So I think people have wanted to know about our case and contact investigation data, and we've had some time to pull it together. And unfortunately, I've forgotten what ACT stands for, but it's our system for case and contact investigation. And we put that up in July. We were using a different system before. But this is just to say what the staff have been doing in the COVID response since July. We had initial contact with cases of 2,694, and then have conducted 9,566 monitor assessments of those cases. Among contacts, we've had 2,283 initial contacts, and then 15,898 monitoring assessments of contacts. That's a lot of time with people. The average has been about 3.5 close contacts per case. Since mid-August, we've determined that 8% of close contacts have converted to cases. And then for the cases reported in the last 2 weeks, because we thought people would be interested in what people were doing in the last 2 weeks. First of all, this will not add up to 100% because it's beyond, because people can do more than one thing. 33% reported contact with a known case, 21% in our household, 12% in the community. 45% reported working during their incubation period. 17% reported going to a gathering, for example, a wedding, funeral, or party. 21% reported going to one or more restaurants. 15% reported traveling out of the DMV area. And 7% reported going to a gym. Not surprising, we didn't include grocery stores because we know people are going, but typically people aren't spending, their goal isn't to sit in one place at a grocery store and talk with people. Ms. Garvey, you have a question.
Yeah, quick question. Thank you, Ruben. What I'm not clear on these cases that were reported that they've been out and about, was this before they knew they had COVID, or was this after they knew they had COVID?
This is before they knew they had COVID.
Okay. Okay.
So this is the information we collect from them during our case for contacting them. So thank you for that clarification.
Good.
So what we look to see is, are there patterns that we can maybe identify? The good thing in one sense is we have not seen patterns of a particular place being identified as a spreading sort of thing, but it shouldn't surprise us that if you're allowed to go out and do things, our community is going out and doing things. Mr. DeFerranti, I believe you had a question.
Actually, I think that's helpful to hear. I think Mr. Dorsey, did you have a question?
Well, thank you, Mr. DeFerranti and Dr. Varghese. So the 45% who reported working during the period, are those all working outside of the home, or is that working generally?
Working outside of the home.
So is it fair to presume that a large share of these case contacts are involved in what have been described as essential work? Do we have a sense of what the local workforce is doing in terms of telework versus in-person engagement at a workplace?
Well, so this would be those who reported working outside of the home. We wouldn't count teleworking within this statistic.
Right. I guess what I'm leading at are a great deal of, it seems that then a great deal of our cases are coming from people who are engaged in essential work.
I would not go that far. What we're saying is these are the activities that people have engaged in. So these could be places where they have gotten exposed. That's the most we can say.
Okay. Thank you.
Welcome.
Got it. And I think Mr. Karantonis, you also had a question on this one.
Yes. Dr. Varghese, you mentioned before that the disproportionality of impact in terms of testing right now, testing positive right now, continues to exist, but all groups were increasing. Does now this statistic tell us something? Because we know, for example, that essential personnel tends to be, there is a larger representation of minority, of, for example, the Latino, of people of Latinos and others, minorities here in Arlington who work these essential jobs and are more exposed, as we see here.
So this data could be, I can see if the staff can break it down further to see by race, ethnicity. I just don't know how robust that data is for the numbers to be able to run that. Mm-hmm. We do have the testing data, which of course is showing who gets infected. So I think it's reasonable to say that those individuals are, of course, going out in the community. Going to work is just a proxy in many ways to say they're outside of their home bubble. Basically, if you can't stay at home, you're going to risk actually getting exposed in the community, bringing it back to your household, and then exposing people within a household. But well, if staff can get any more granularity on this, because we don't actually have a definition of essential worker. We originally said those things at the very beginning to help people understand why some people may be out and others aren't. Grocery stores, I don't think anyone would ever say would be something other than essential. And so they had to be open because you couldn't get your groceries necessarily always from a delivery service. You'd have to have credit cards and things, and not everyone has those things. So there is no universal definition of essential, but it's more a catch-all phrase of like, I would consider myself had the opportunity to telework. Essential workers often don't have that ability, but that's my definition.
Yeah, and most people in service jobs don't have this opportunity, so that's they don't have this alternative. One question on the method here. This is all. These are, this is all traced basically by hand. There is no data from the app that the governor has promoted a few months ago, etc. There's no automatic tracing here, or app-based tracing.
So the app-based tracing is once, if a person has the app, we will give them a PIN if they turn positive, because they only, so if you're positive and you have the COVID app, we will ask you if you have the COVID app. If you do, we can give you the PIN to unlock it, and then it will send to other app holders if they were within a certain distance of that individual for 15 minutes or more. So that's the only thing it really does. Then let them contact the health department to say that, or that you need to have quarantine and so on. It doesn't provide data in reverse, because that's one of the things that we made sure they didn't. There are a lot of people who are concerned about government apps and what it's collecting. Mm-hmm. So this is actually, this information that I presented here from staff, this is taking it from the electronic database that when they interview the cases, they're actually asking questions about where were you in the last 14 days, who did you come in contact with, where, and then they, based on that, where was that? Is it at your workplace? Is it at school? That's what they're collecting at this point, and this is how we then are aggregating the information to give people a sense of what's going on and where people are going in the community. And none of this surprises us. I think we all know people who've been in these situations. You know, I am hard pressed to say don't go to a gym, because that's a good thing to do for exercise, because you may need it for your health.
I also noticed that you don't list any as a category here, use of public transportation.
That didn't come up as a major activity, so
Okay.
we didn't put all. It doesn't mean that there weren't some people using that.
Okay, thank you.
Thank you. This is almost a peek into the contact tracing that you've been doing and your team has been doing for so long, so well relative to other portions of the state, at least to my understanding. Mr. Dorsey had a question.
Certainly, I think Ms. Crystal was there first, Mr.
Oh, sure. Sure.
That's all right. Thank you so much, and I'm happy to yield. Thank you very much for the presentation, Dr. Varghese. I wondered, is the data set for these cases and the contacts reported here large enough that we could do crosstabs with, for example, age groups while still protecting the privacy of the individuals, or does the N get too small in those circumstances?
It's a good question. It depends on what the crosstab is. So, and we just have not gone to that level. Part of it is we're not sure how it will change the intervention. And honestly, right now it's a resource issue. This past week, with how many cases there were, we're keeping up, but it's been more taxing. Just to let people know, the Arlington Mill site alone, we had 450 people come through last week, with 1 day removed because of election. So that was a banner week. And unfortunately, we had about 10 to 15% of those results being positive. That's just one site. So we've been focusing on getting the case data as we can. We'll see if we can cross tab to see if there's something that comes out. But that's why we do look at this. So it's a great question. If we thought there was something that seemed a pattern, we would look to see if there's some specific thing that we need to advise people on.
Thank you. I appreciate that. And I certainly, I think that the individual health response, as well as the public health response that you all are undertaking, is indicative of how much is on the team's plate right now. I ask because I do think it might be helpful for us from a policy-making perspective. Certainly, we've had robust conversations amongst ourselves about, for instance, whether individuals going to restaurants for nightlife is a key driver of increases in that 18 to 34-year-old population, for example. So I think it could be illustrative if there's a way to do those crosstabs while still protecting privacy, as we start to consider more policy interventions, as well as the most important work that you're doing in terms of testing, tracing, and helping members of our community maintain their health and get information. So perhaps a down the road thing, it does certainly seem like the takeaway from the presentation you've given us today is that we are in the middle of a second wave of this crisis. And so I think that the areas where you focus are the right ones for now. So thank you.
Thank you.
Great. Instructive for as we go forward. Mr. Dorsey.
So thank you for that. So Dr. Varghese, looking at the third bullet and then the third and fourth bullets. So if my math is correct, it takes, for every individual to produce, it takes more than 10 individuals 10 contacts to produce a case. And we're seeing, 3 infected people leading to those 10 plus individuals. It seems really low, or in a good way. It seems like that's a positive thing that we're not seeing contacts convert to to cases. I was wondering if you could give us a sense of how this informs the R value and where we stand locally compared to statewide or nationwide. Is the virus transmissibility low here, or is this just a particular snapshot in time where it looks pretty favorable?
So it's a good question. We do not have local R value data. We have state level data, and we also have what DC, the District of Columbia, has done. I often look at the District of Columbia as the proxy for us, and they've been an R value above 1. It's a reproductive rate of, if it's higher than 1, it means that there's evidence of more spread and happening more quickly. I think all of this is indicating that we've seen that there is, while there may be more testing going on, I think it's clearly showing that we've seen more spread occurring, and because of people interacting. And so if I wasn't, I take the opportunity to be that clear. It looks like because of all of the gathering we're doing, we're seeing more test positivity because there is spread. I can't quantify it in an R value for Arlington. And that's one of the things that I've asked the Council of Governments actually to think about, seeing if they can have the resources to do an R value for the National Capital Region, building off of what the district has, because that would actually give us an indication of what's happening in our region, because we're structurally similar more to the NCR than we are to either Maryland or to Virginia. But they have to figure out a way to maybe get to that point. But the message here is that it looks very much like we are seeing spread and that it's increasing. I'd like to be wrong, but we're not the only jurisdiction seeing this, and we've seen it in DC, and we just had the Council of Governments meeting on Monday with the health officials, and my Maryland colleagues were seeing rises. The district has reported rises, and my colleagues in Northern Virginia have seen rises as well.
And I know the data that we have don't prove this, but I think it's pretty reasonable to conclude that the contact, in light of increased spread, this robust contact tracing effort is reducing transmissibility of the virus in Arlington, or at least that's what this snapshot leads me to form as a reasonable hypothesis. So thanks for the work.
Thanks, Steph. Thank you.
Great. So we're this slide is getting us lots of questions. We have 4 or 5 other areas, but let's do one last round if we can. Ms. Garvey and then Mr. Karantonis.
Thank you, Mr. DiFranti. We're probably, this may be coming up ahead, and so Dr. Verghese, if you want to talk about it later, that's fine. I wondered if you wanted to comment on how are the public health divisions doing with cooperating in the National Capital Region. I know at times it's been a little bumpy, and there have been some efforts to sort of improve sharing of data and being on using the same kinds of data to make sure we're doing apples to apples comparisons. Has that improved some? Is that continuing to be a work in progress? Any comments you'd like to make? But I realize you may not want to comment too much, but be interested to know.
Great question. The health departments in the region have always cooperated very well. The issue sometimes becomes the local state issues. There's only one state health department in the National Capital Region, and that is the District of Columbia. So when state level decisions need to be made, that's between the DC Department of Health, the Maryland Department of Health, and the Virginia Department of Health. None of the localities other than DC get to participate in those sorts of discussions. Having said that, they do work reasonably well. And so recently, through the Council of Governments, building off of the success of the Essence surveillance system that was created for syndromic surveillance back in 2002 or 3, the 3 states built off of that through the Council of Governments to agree to sharing electronically the contact information that crosses state boundaries. So that makes it a bit easier to get some of that. It hasn't been implemented yet, but they went and created the MOU to be able to start the electronic process. So without that, we go through our state health department colleagues to get the information, and sometimes necessary, then they rely on me to call my counterpart in any of the localities to get that information and vice versa. So I think on that level, there's good cooperation, Ms. Garvey.
Thank you. And is there any sense of the percentage? I'm guessing no. What's the percentage of the population wearing masks in any given? Is anybody kind of trying to keep track of that?
There's no way, we have no good metric for that because there's no way to monitor that.
Yeah, thanks.
Mr. Karantonis. Sure.
Dr. Verghese, I want to echo the thank you, my colleagues, for everything that you are doing and the work that you're putting into that. It's just for to clarify and you'd structure my mind around the numbers that you are presenting. So along the comment of Mr. Dorsey, the R value, we don't have, I just want to understand that, we don't have a reliable production value, an R value for the metropolitan region, but we do have one for Northern Virginia, correct?
No.
No, not even.
No.
Okay.
This is where we've asked the state to at least do it for Northern Virginia. That's been considered, and I'll leave it at that.
Is there any implication from that fact, or if we look into a more robust testing and consequently tracing a regime even more robust than this, is there any implication for this? So should we looking at, for example, dramatically increasing tracing, making testing even more openly available to everybody? The district, for example, has, we provide free and open testing, no questions asked, except for residency at the Arlington Mills site. The district is doing more. Is there an implication? Is there a possible, conclusion there? Should we discuss that?
So the best I can say, Mr. Karantonis, is that when DC first did it, they had plans of doing 10,000 tests per day, or no, actually 50,000 tests per day, and going through cycles of their whole populations in a 10-day period. They actually ended up closing many of their sites because they weren't getting that sort of uptick. So part of it is once you make something available, in many ways, often people then don't pursue it. And unfortunately, I don't think we have a culture that actually, if government says go get tested, that's necessarily going to get followed. This is why I would prefer some sort of national strategy that the 50 states actually we start selling this concept of doing more testing and then encouraging people that if you're test positive that you want to cooperate and stay at home. But that actually requires that there be a concerted effort by everyone to support those individuals. Arlington is doing that, but we're one locality and we can't solve the larger problem because we go elsewhere and we're going to get possibly exposed. If we could hermetically seal Arlington and make us still live in a hermetically sealed environment, then it may be a different discussion, because then we could say, let's put an end to the transmission among Arlingtonians, but then we're controlling how the virus gets into Arlington itself. But with our open borders sort of thing, I think this is a discussion for the region and the nation, and I'm hoping that with the new administration, we may see a more concerted effort versus a state by state and region by region sort of approach.
Okay, I understand that. I was rather after the question whether increasing our testing capacity at any rate, or our testing regime, or modifying our testing regime so that we test more people would inform our decisions that we may have to take later. Countermeasures basically. But this is for a longer discussion at a later point. Okay. I just wanted to understand what the R, how we can get closer to having an R value.
Well, the R value is, I think we could have it. We need the statistical calculation ability, and the state has data that we don't always have access to. So if that's the question, we've put it to the state level jurisdiction to see if they could provide that. That's why I have persisted at the Council of Governments level to see, can they get access through their existing resources to the Northern Virginia data, and having the capacity that the district did through the Johns Hopkins effort, is there a way to add our data to create a R value for the National Capital Region? Because I don't believe that it's that we don't have enough information potentially to do that. We don't have the resources to create that, and doing it just for Arlington is not something that I've always ever seen as valuable, for the sole reason that, given that germs, as you know, don't respect boundaries, it would be good for us to see at a minimum what Northern Virginia has, but even better if we could look at it for the entire National Capital Region. So I apologize if I didn't understand your question in relation to the R value. I would love to have that information. The question then still becomes, what will we do policy-wise, given the fact that the policy decisions about opening and closing typically rest with the governor rather than with any of the localities.
Okay.
Thank you, Dr. Varghese, both for persisting at the state level and for your, I think it's a shared view the board and the county that a national strategy is necessary and important for sure. Well, next we can continue with questions. I'm sure we've got a few other topics related to COVID, so I'll leave it to you.
I just want to remind people the next two slides are about testing, and this comes from our dashboard. And you can see at the very beginning the percent that was in red and orange was a large part of the tests that are available. Over time in Arlington, the testing capacity has increased, both what we offer through the county government as well as all the local providers, and then this also includes any of the home testing as well. So over time, people who need to get testing can get it. This though goes to if there is a public policy desire to have free testing available for everyone on demand. That's a public policy question. The only reason why public health doesn't have the bandwidth is that if we take it on, I become the doctor for the entire county, and we have a legal obligation to get test results back to everyone and do follow-up, and that is not something that's individual healthcare at that point. And that's why if there's a mechanism to approach that in a different way, and that's a policy desire, but each test costs $50 per person currently, so it becomes a rather daunting concept. I wish we could actually take some of the information from other countries. There have been some countries that have come up with a $5 test. Not as accurate, but it may be the type of thing that it could be worthwhile for businesses to take on, because they may be able to add it to their price point for products and so on. The next slide just is a tabular version of that data, and you'll see at the beginning we'd have March 15th, 40 positive tests out of 210, but that was 17.45%. As time has gone on, it initially peaked as high as 47% back in April. And then as the pandemic continued and testing increased, the percent positivity started going down into the 3 to 5 range. And that's where it's roughly been for the whole community. But it is starting to creep up even for the whole community. And as I've said, when we disaggregate and look at the Arlington Mill data, it's gone as high as 15 to 17%, depending on the week. So it's good that we have it, but the real issue is where are they getting contact with a germ and then bringing it back to places, and that's not always easily findable because we have community transmission.
Thank you, Dr. Varghese. Takis, you have a question?
Just a brief clarification again. This is among the people who are getting tested are people who are, most of them, the vast majority, has been symptomatic, correct?
It depends on which test company or test group that you go to. Most of the in-person ones, you are supposed to have symptoms to do that. If you take some of the at-home tests, it depends on the wording of it. It's like, have you been in a building with X number of people, for example? It's just off the top of my head. That may get you the opportunity. They may then decide, oh, well, you had a higher risk of exposure and you're a diabetic. We're going to give you the test. So it depends on the realm, but the vast majority in Arlington, including our Quincy Street site, it's symptom-based, yes.
Okay, thank you.
And then just, this is just to confirm, I do notice that perhaps it's a trend, Dr. Varghese, in the October 18th, 25th, November 1st, you see the percent positivity of PCR tests going up. And I assume that on November 8th, we just don't have conclusive data, but that trend still may be continuing. We just don't know. The 2.77 is just only on partial data. Is that right?
That is correct. So that goes back to what Ms. Garvey had pointed out earlier on the other slide, where you have the 3 weeks in shading in gray. There's going to be a delay, so we don't always get results. Even though there are some places with electronic systems, the delays even with that are often days across the nation. So that's part of the issue. We work to try to get those people up and running better. The other increase is the rapid testing. Unfortunately, Most of those don't come with electronic modules, so therefore being able to get that information, we then ask for the positives over the negatives, which means that there could be times where we're going to look like have a higher test positivity rate, but it could be because we're not getting the negatives, because if the providers can only get the positives or the negatives to us, we're going to choose the positives, obviously, because that helps with our effort. So this is the hodgepodge nature of the laboratory services across the nation. So that's my observation.
Thank you.
Okay. If there are no questions, I'll go on to the next slide. So, and these are the last slides, at least on vaccine, because I know that people are interested. So I thought I would focus on kind of what Pfizer had put out and put this all into context. So what people heard, Pfizer put out what they call a phase 3 study. There's been phases 1 and 2. Their press release that they put out said 90% fewer cases of COVID among those vaccinated versus the unvaccinated. They initially thought it was going to be some number between 60 and 70%. So 60 to 70% would be good. 90% fewer would even be better. But notice I've also put the word press release. While we have no reason to believe they would put out false information, a press release is not a scientific study. So there's a process that has to happen, but let's continue. They make the point the efficacy of the study may change in the end as more data comes in. So they reported this about 3/4 of the way through a phase 3, as I understand. But that still means they have a couple more weeks of data that have to come in, just like the laboratory data that we've talked about. So it's possible it could change, but I'm going to make the assumption that their scientists believed it enough because they know that this is going to also have an economic impact on their believability. They're not going to make this up. And based on this, if their techniques are working well, the other vaccine makers are doing similar things, and the Pfizer vaccine is messenger RNA technology. The one thing that has to be pointed out is right now, there's never been an mRNA product that has ever been approved. Doesn't mean it won't be, but this is a way of saying this is new technology. They have really been, the one thing calling it Operation Warp Speed in that sense has been appropriate. I think they are trying to do things differently. The FDA has to consider a vaccine under an EUA or emergency use authorization once 1/2 of the patients are observed for at least 2 months or greater following their second dose. So it's my way of first reminding people, most of the vaccines that are being considered are going to require 2 doses. You get dose 1, and the second one would have to happen 2 to 4 weeks later to get full benefit of the vaccine. So they have to have done all of those in those first phases, and they are looking to complete that number of patients being observed for at least 2 months and looking at the safety profile. They're not going to send it forward if it's got a horrible safety profile, but we won't know until we hear that there's been an FDA submission. So this is a bright spot, and now I'm going to talk about the caveats. There's no information yet on whether the vaccine prevents severe cases from happening, those who would need hospitalization or those who die, because there just hasn't been time. It's been good that they haven't seen that, but you can't make some of those conclusions because it all depends on who they vaccinated. They vaccinated about 44,000 people, great number, but that's not as good as over years and years of experience. We also have no information about if this vaccine can prevent the carriage of virus in the nose to prevent asymptomatic spread. So it could be that people can protect themselves from getting COVID, but if they're still able to carry it and spread it to other people, well, at least it's better that they're not going to get ill themselves. But if they can still spread it to other people, there are limitations there. And we don't know with the current data how long it will protect against infection with the virus. So this could be one of those situations where maybe it's like the flu shot. You need an annual vaccine to make this work, still to be determined. And just to remind people, it does cause side effects, just like other adult vaccines, probably kind of that flu-like achiness, maybe some arm soreness. Some of the initial reports say that it's likely 1 to 2 days of illness, which they point out could make some people reluctant to take vaccine because people believe if there's any effect that they feel that it can't be good or worth taking. if I could get through the next slide on vaccine, it may answer some questions that and then take questions at that point. So, case in point, FDA has not seen the data. It's only a press release because it's not ready to see it because Pfizer hasn't put it out yet. And FDA at some point will have to review and vote on it. After that, the CDC and its ACIP group, the Advisory Committee on Immunization Practices, has to review the information and then decide and recommend who the vaccine is best for. And just as to get people's expectations managed, it is unlikely it will be recommended for children at this point because trials on children have not begun here in the US. That's not unusual because we typically wait for trials to be completed among adults. The problem is now everyone's going, well, how could you not give it to children? This has been long-term public policy on vaccines that they don't want to try vaccines without first seeing how they work on adults. So there's going to be this tension in public policy. Now it's like, well, shouldn't they get it? But going back to the fact that we haven't seen as many cases among children, focusing on adults seems reasonable. And we know that they're working on figuring out how to start thinking about doing those trials among children, but they have to do it through FDA processes. And then prioritization would be recommended by CDC and the ACIP about which groups should get it. Typically, if you go on the past recommendations for other events like this, it would be healthcare workers and those most at risk, so those in nursing homes and long-term care facilities would be the first groups for the limited amount of supply, and then getting to vaccine supply. They remind us initial supplies will be limited even if authorized. For the Pfizer vaccine, they were saying perhaps 50 million by the end of 2020. Sorry, it feels like 220. And that number is for the whole world, not just for the US. And they're anticipating producing up to 1.3 billion doses in 2021. And then vaccine distribution issues, which we're working through even in Arlington and with the state. Some of these require ultra cold chain needs. So for the Pfizer vaccine, it requires storage at -70 degrees Celsius, which is -94 degrees Fahrenheit. So we are working with the state and our partners to see if we can order those now. Other things that the federal government has done successfully, and we hope there will be local uptick. CVS and Walgreens have agreed to help provide with vaccine distribution to long-term care facilities if those facilities sign up. We've put the information out to those places. When I get that information, we may be making special pleas to anyone that said no, but we can't force them to. But it would be really helpful if some of those things were done in the private sector and taken care of so that public health doesn't have to do all of it. Private providers have also been sent the information and they can sign up, but of course they have to be comfortable with vaccination. And we are planning as a county as well. And the state has told us in general, each health district like Arlington should anticipate by a combination of efforts of providing vaccine for about 35% of the population, not because we couldn't actually give it to 100%, but given people's vaccine hesitancy, and once it becomes plentiful, just like what happened with H1N1, suddenly interest in the vaccine went down. So those are just some of the realities of things. So if we keep saying it's not available, maybe that's the way we would drive more people to it. But people also have the option of, if they feel that it's too new, they don't believe the safety data, no matter what people say, it's perfectly up to them to make those decisions. I believe that's my last slide, so I'm happy to take further questions.
Sure, Mr. Dorsey. Thank you, Dr. Verghese.
Thank you, Dr. Verghese. So is there any sense with the Pfizer vaccine, you know, the 10% of people who received the vaccine who contracted COVID, is there any sense that the severity of their illness was, less severe than a control group, like the influenza virus, or the theory behind it, that even if you contract it, it'll likely be a milder version?
We didn't learn that from the press release. So that's the thing so we don't know that information yet. And that's why what we're looking to see is when it goes to FDA and they give them the actual data to review and put out the information. So all that we can tell is they were excited enough to let people know that they saw these things. We don't have more details. And so, as I said, my suspicion is they're a reputable company and they don't want to lose market share later on. So they probably crossed their T's and dotted their I's on what they could actually put public in it. But the proof is going to be when they make their application for the emergency use authorization. The data then will be reviewed by FDA. Hopefully they have to put out enough for ACIP and others. And then Virginia and other states are going to be reviewing that data as well. I'm on the vaccine advisory group for the state looking at safety information. We're not going to look at the primary data because they're not going to reveal it to us, but we're going to want to know that the processes that normally would look at and quality of studies are being looked at, that we would do that and make sure that at least from a process perspective, we think that it's safe and it looks like it's effective. So that's as much as we know now. I wish we knew more, but.
Well, but you feel confident that we'll be able to pour over all these data in time for there to be a significant rollout by the end of the year if all is, no, okay, you're not, okay.
Well, I think everyone's being optimistic and I would love to hold out hope, but the thing is, when there are 50 million doses from one company available for the whole world, we don't know how much is coming to the US. And then we still haven't heard which groups are going to be prioritized. But if it's going to be hospital workers, EMS, and nursing home individuals, the real question is, if they give each locality a certain amount, what if the math doesn't add up? Mm-hmm. Then who's going to be prioritized among that? If I were to really think about it, and I may not make people happy, I would probably put the nursing home residents first because they can't wear PPE, whereas the other individuals have access to PPE because we can actually vaccinate the elderly and reduce their risk of dying. That would be, I think, an important thing to do because we had the most deaths in Arlington happen. 3/4 of our deaths occurred in long-term care facilities, whereas, knock on wood, we haven't had those things occur among hospital individuals or REMS, hopefully because they had the right equipment and were using it properly so that there are means to protect them until more comes in. But this is that balance of like, how do you decide, especially when there's a limited amount of vaccine available, and they've been trying to have us temper people's expectations. I think we'll have plentiful supplies, hopefully after April. The real issue is going to be between January and April, how much is available and how are we going to distribute it? It is going to be a very interesting, unpopular activity that public health and others are going to be part of.
Thank you.
Sure. Well, I think on that note, I think Mr. Mark, you may have had wanted to share a couple of points, and then Mr. Carantonis.
Thank you, Mr. DiFerrante. I would refer all of the people who are out there listening to an interview that was done with General Perna, who is appointed as the head of Operation Warp Speed. It was on 60 Minutes on Sunday. There are 2 or 3 points he made that are worth emphasizing beyond what Dr. Varghese has mentioned, which is that a lot of the conversation is unfortunately a little bit optimistic about the receptivity of people to take vaccines. Mm-hmm. Now, General Perna was asked about the one thing that makes him most anxious, and it was not about distribution, it was not about supply, it was about willingness of individuals to take the vaccine. Mm-hmm. And recent surveys have shown that only 60% of doctors would take a vaccine, only 40% of nurses would take a vaccine, and then the numbers drop from there. So I would say one of the huge challenges we have as a nation and a region, but certainly as a community, will be to convince everyone once the vaccine is here, tested, and viable, that it is a good thing to take. And that I hate to sound so lofty about it, but it could really be the challenge of our lifetime to get everyone in our community, those people who people who believe in science but are somehow very scared of vaccines, and those who are doubtful about it, to sign up for this. And the best way to make that happen, and I'm looking at Ms. Garvey on this, we talked about this, is trust. To find partners in the community that are going to be willing to sign up and trust. As trustworthy as I know everyone on this phone call is, our pleas to people to take the vaccine will only go so far. We need individuals in the community become partners with us. That's something that we've only started thinking about. And I wanted to mention that is going to be a colossal challenge, something that none of us signed up for, but I'm not sure we welcome it, but it's the biggest challenge we face. So I will stop at that point.
Well, that's further sobering. I mean, Mr. Karantonis, go ahead with your question.
You're muted.
You're on mute.
To Mr. Schwartz's comment, yeah, and this time is a vaccine that really saves lives here and now. That's not a abstract thing. It's not just a prophylactic vaccine. This is nothing that people should be waiting, or the moment that we have an availability, we need to see what partnerships we can energize and leverage so that we get everybody vaccinated. But to that, so we are waiting for CDC to release guidelines on prioritization, right? But we know already from other countries in the world what kind of prioritization we most likely will be seeing. And Dr. Varghese, you already mentioned that. Do we know, are we ready to say this is the number of vaccines we would, I mean, under the most likely scenario, this is the number of shots that we would need? So for example, for our healthcare personnel and for, the most vulnerable ones or first line workers, etc. Are we ready to send a telegram and say, yes, we need like 2,000 vaccines or 3,000 vaccines from the first batch?
It actually doesn't work that way. We have given them the data for the various groups, but we won't get it allocated that way. Recognizing what happened in H1N1 when we actually vaccinated school children, there was 1 week we got 3,000 doses for a system with 30,000 children. And so that is going to be the reality is we could possibly get 100 doses and we have to decide what we're going to do with 100 doses that week, because it all depends on how much is going to come. So we were literally making decisions week by week of where to allocate and how to allocate it. So we have rough estimates, obviously, for each population. And going to Mr. Schwartz's comment, we may know what certain groups, in theory, what the population number is, but will they then accept it? But we have to still offer it to them and then say, if you don't take it by this date, we're going to shift to another group. So that's going to be one of those uncomfortable things that just happens with every vaccine issue. Not everyone is going to take it. That's why, if you heard, I mentioned the state is not anticipating initially more than 35% uptake, which for a population of, say, 100,000 adults seems like a small number, but that would be a great start and obviously we can do better than that. To your point, unfortunately, that's one of the things that we don't know yet from these studies is, does it actually reduce the death rate? We haven't seen that. It doesn't mean that it can't happen, but that's what some people may say, unless you've got that data, I'm not so sure I'm going to do it. And that's going to be one of the issues of, do we take a leap of faith as a community if the safety profile seems weak? I think it's a reasonable thing to do. However, people have to make personal decisions for themselves.
Well, thank you, Dr. Varghese. That last note seems consistent with, you started by mentioning the concerns we all have about COVID fatigue. And I think different times, each of the members of the board, Ms. Crystal, I think you mentioned a second wave. Dr. Varghese, you mentioned that lives are still at stake. The last two slides feel like and the 60 minutes that the manager mentioned, we are eager to get to the next stage, and it is important that we're informed on all the slides, but we are still facing a huge challenge, and we're some time away from getting to the end of this challenge. So that's a note that I think is sobering, but still necessary for our community to know in different ways. So I know that there's, I think that covers most of the topics. I do think, Mr. Schwartz, you mentioned also a discussion of school at some point. Do you want to lead us in that?
Yes, Mr. DiFronte. There's one or two pieces of information I wanted to cover. The first thing I wanted to do was to share some information that I have received from the superintendent, and I will do my best to share my screen here and see how that works. And let me know if you can see this.
Yep, we see it.
Okay, so this was a slide that was prepared last week, so keep that in mind when you see some of the references here where it says details will be communicated next week. That's this week. I don't know that the superintendent has actually presented this fully, but here are some details. We've received a number of questions from individuals about what the county is doing to support schools, but what I wanted to get to at least this information out to the community, which is that the public schools are planning to provide some in-person learning support to 150 students, and you can see the information here rather than my reading through the entire slide. It's going to be at 3 locations, and those are Drew, Hoffman, Boston, and Ashlon. And at those elementary schools, there'll be 50 kids, and they're going to be following all sorts of the social distancing guidelines and protocols that APS deems important. And there, you're going to get a lot of details on that, and it's going to be supported by extended day staff. So I thought that was important to put out there. And I know there are additional programs that schools are probably going to either have announced or will announce, where they're, and I think Wakefield is one of them, where they're asking kids who need some additional supervision to come in for in-person opportunities for that kind of supervision. So I will figure out here how to unshare my screen. And let's see, okay. What I wanted to do is just to take a minute and address a few points, and then I'm happy to take questions, because I've received a number of questions about what we're doing to work with schools. And I think a lot of that was covered in the October 21st work session that we had that was between the Arlington County Board and the Arlington School Board. So again, I will not repeat all the information that is there. And I'd like to say, at least from my perspective, it's very important to acknowledge the crucial role that schools play in the health of our community, and then also obviously in education, but in the social development of our kids, because that's an important aspect of what happens in schools. And so we have assisted the schools in numerous ways. That's been acknowledged multiple times by Dr. Duran, who for some reason decided to take the job starting in June in the middle of a pandemic. It's done a great job working with the school board, and we've provided a significant amount of financial assistance, and also we work with them every day trying to work through many of the challenges they have. One of the things I wanted to address very squarely is we often get the question of, well, why won't schools open? Can't the county tell them to open up? Or why is it that the county's telling them not to open up? And so I know that that's come up a number of times in town halls. And so we have Dr. Varghese here, and you know, it's funny because Dr. Varghese is he's a doctor, and people forget sometimes their relationship with doctors. I go to doctors all the time. A doctor gives me advice, okay? Doctor doesn't tell me what I must do and gives me no choice. Doctor gives me advice, and that's what Dr. Varghese does. Dr. Varghese gives advice to schools, and the school leadership makes a decision. It's their decision. It's never an easy decision, but I want people to understand when they ask us, why don't you have the schools do A, B, and C? That's like saying someone coming in to a doctor and saying, why don't you tell your patient to do this, that, and this? So I just wanted to clarify that because I think it's a question we received a lot of the time. By saying something like that and making it so clear, I do not want to take away from the difficulty of the issues, because I just highlighted not only are health issues at issue, those health issues include not only the physical, but the moral and spiritual well-being of our kids. And so those are incredibly difficult issues. And so I do not, and I would not switch places with Arlington parents. Both of my kids are out of schools right now. So we have our own series of challenges, but they're a very difficult set of challenges. But I did want to lay that context because, you know, Dr. Varghese gets a number of questions from people, tell them to do this or tell them not to do that. And I think it's very important people understand, as it's been seen in the last hour here, Dr. Varghese, not just him, but his public health staff are working incredibly hard, literally 24 hours a day, to keep our community healthy. So I hope people keep that in mind when they raise their concerns about what's going on in schools. And I know they express appreciation for the work our public health staff, but I hope that this provides a deeper context. So I will stop my comment there and then turn it back to you, Mr. DiFerrante.
Thank you, Mark, Mr. Manager, for your thoughts. I think it's important to reveal, to kind of clarify that it's the role is to provide the best available science and information, and ultimately the school. There's a role for school leadership, even as we collaborate and have made so many efforts, as you mentioned in our work session, on virtual learning. That is a different thing entirely as from being a parent. And I'm not a parent. We got a couple of colleagues as parents, and it is a whole different level of challenge, but one that we have to provide the science, and then there's a role for schools to take leadership, and there's a role for the county to work with schools, of course, towards that end. So any comments from colleagues? I don't see hands, but certainly we have been hearing, just as Mr. Schwartz, you mentioned, we've been getting comments. We are listening and paying attention to those comments. We're also mindful that there's a difference, as Dr. Varghese mentioned, between early press releases and the science that is there and the actual work we must do. So, Mr. Karantonis, you're on mute.
I apologize. So thank you, Mr. DiFerrante. Thank you, Mr. Schwartz, for the explanation. I mean, given the numbers that we've seen from Dr. Varghese and all the detailed explanations, I feel, and I believe I'm reflecting, I'm just transmitting the general sentiment. We're, in the news every day, we see entire countries going on lockdown right now, governments taking very painful decisions, having to manage a second peak or a second wave of infections. So the question is how, and I recognize if there is something that I read from the numbers is that we've gotten way better in understanding the disease, understanding the spread in community, testing, tracing, and also, I guess on the other side, on the clinical side of this, also, managing the disease with those who have been infected. But nevertheless, there is a serious concern that we may have to face tough decisions, lockdowns, etc. This is not only, influencing our discussion about schools. This is also, and I guess this is also influencing our discussion about our economy, our small businesses, and also public services like libraries, for example, that we have been talking about finding a way to make the service of browsing for kids again available. So what is the state of thinking that we should be doing here?
Well, let me add one or 2 points on that, and I have Michelle Cowan here, and Ruben can add. So questions, I'll give you an example for library services. I think that we have, as you mentioned, the one thing that is really stark is what we have learned from March until November. It's been a very long time. And I think it would be wrong, even in light of increased incidence of the virus among certain parts of the community, to say that it is out of bounds to have people come indoors at any time for even seconds or a minute or two to do things. And so given that, I mean, there are some plans that we have put together that would expand in a very limited way our library services. I think we'll be talking about those with the board in the budget context. And also we have had some limited indoor activities at our recreation centers. And I'm gonna not only pretend, but actually swear that I can't remember the details. And so Michelle can add to those. So I think there's an opportunity to do that. But what's critical with all of that is we must follow all the protocols. So it's the virus will, as best we know, not spread in certain sets of circumstances. And if we religiously follow those circumstances, I think that there are some things that can be done. So to follow on to my comments, I'm going to let Michelle add a little bit about what we're doing in recreation facilities, and then also Ruben to add whatever comments he wants on that.
So hi, it's Michelle. Can you all hear me? I've been having a bunch of problems with Teams. Great. Yes, so we have opened, I think in a very safe way, a series of fitness centers across the county. I think you all know that. Madison, Arlington, TJ, and a couple of other places. We have Arlington Mill, as you know, is open for Aspire and for childcare. And right now, we've also on a very, a selective basis, we've been working with DHS in opening certain in-person services. We're working on opening the Arlington Employment Center for limited computer use. We've been opening certain in-person client services, again, in conjunction with public health and doing it as safely as we can. Right now, we are working with parks on our next set of possible reopening of services in some of our community centers, which we would expect would begin in the calendar year. So that's where we stand now. We're just working through all those details now, and we'll be back to the board and the manager here in the next couple of weeks.
Thank you, Ms. Cowan. Dr. Varghese.
Well, I think our manager said it very well. I think we are balancing various issues. And so one of the things I remind everyone, at least from the health perspective, there are various populations involved here, not just one or another. And so you have to think about the population of, for example, children, the occupational health needs of workers. There is no one simple formula here. And so that's why we provide the information we do to leaders to consider all of those things. And I pray that they can figure out the right way to discern what the path forward is and then what schedule. That's all I will say.
Thank you, Dr. Varghese. Unless there are any other questions or thoughts, I do think just a couple of data points. One is Dr. Varghese mentioned earlier that we did flatten the curve to avoid overwhelming our hospitals. So there is a note of positivity there. We are in a moment where in Arlington, the last couple of days, our test positivity rate has been above 5%, which is a key metric. So we have more work to do, both with respect to serving our young people and also with respect to keeping everybody safe. This is a very 2020 will end at some point. We must know that. So we're working to keep getting through this challenging moment. So that's the couple of thoughts I would close with, unless colleagues wanted to add. Seeing no hands, thank you, Dr. Varghese, Mr. Schwartz, and colleagues. That is, I believe, all to come before the board today. Any other concluding thoughts, Madam Chair? I think we're good to adjourn for the afternoon, if that works for everyone. Great. Thank you. Stay safe, everybody.
Thank you, everyone. Appreciate it.
Thank you.
Stay well.